A very good morning to all of you, and at the very outset I'd like to thank Dr. Rishi and Dr. Hema for their kind invitation to this prestigious meet, and I'm really very grateful and I feel honored to be part of the plenary session. And thanks to Dr. Bhattacharya for really having given an elaborate introduction to me, which is, I think, I don't need all that kind of a thing. That is all past. So I come to today's main topic that is given to me is the role of moisturizers in atopic dermatitis. Now, at the very outset, I'd just like to mention that as you know, moisturizers, we make this as a routine practice, as a habit on the skin. You know, daily in and out we use various kinds of different things as moisturizers, but today I would just pay attention to the science behind moisturizers and in atopic dermatitis, particularly because moisturizers, they constitute an important aspect of the non-pharmacological management of atopic dermatitis. We all know that AD is a chronic disease. It is characterized by inflammation, which can begin early in life. In children, almost around 3 to 6 months of age is the common age group, goes on. Some of these patients, they are lucky to outgrow their disease, but sometimes it continues into adulthood. We all know that the adult onset atopic dermatitis is now becoming quite common. This is a disease which needs no test for its diagnosis, and it's purely diagnosed on the basis of clinical features and history, which is based upon a pruritic dermatitis, dry skin, a characteristic distribution which involves the flexures and the extensors and the face in infancy, and it settles down into the flexures as the child grows, and later on into the adulthood it becomes confined in the form of hand or foot eczema, or eczema anywhere else can be a manifestation of adult onset atopic dermatitis. Before coming to moisturizers, we must understand in depth the pathogenesis of atopic dermatitis, because then only we will be able to understand the need for moisturizers in AD. So it is a complex disorder which revolves around an interplay of genetic factors, the environmental triggers, and an immunological disturbance which results in inflammation. At the center of AD lies the epidermal barrier dysfunction. So there has been a paradigm shift in our knowledge of pathogenesis of atopic dermatitis. Years ago, before 1980s, we used to be of the opinion that AD results from an immune dysregulation which results in a Th2 mediated response. But after 1980s, once filaggrin gene mutations were discovered, it was clearly proven that it is the defects in the barrier of the atopic skin that leads to an inflammation, and that further gives rise to allergic march that is manifested in the form of allergic rhinitis and bronchial asthma later on. So coming to the genetics of AD, we know that AD patients, they have underlying genetic mutations in the genes that code for the various proteins in the epidermis, namely the filaggrin and the SCCE, which is a protease, and the SPINK5 mutation. Now this model, I think when we were postgraduates, we used to be taught our dermatology with this model, which is known as the Brick-and-Mortar model of epidermis. You can conceptualize that the bricks here are the keratinocytes, and the intercellular cementing substance, it is constituted by the intercellular lipids. Now for the barrier function to be performed adequately, it is very important that the keratinocytes, they lie in close contact with each other. There are no holes in between them, and this depends upon the coating of the keratinocytes. Normally in a normal skin, the keratinocytes, they are coated on the outer surface with involucrin, loricrin, and the outermost layer constituted by ceramides. Similarly, the intercellular cementing substance is also composed of ceramides, cholesterol, and fatty acids. This is the normal skin. So in a normal individual with an adhesive layer of stacks of keratinocytes, there is very little permeability to the external microbes, infections, and allergens. Filaggrin deficiency in atopic dermatitis results in a defective barrier function, and profilaggrin is the precursor molecule of filaggrin. You must pay attention to filaggrin because filaggrin is not only important as a molecule which binds the macrofibrils of keratin. As dermatologists, epidermis is very important for us, and if the epidermis is defective, the rest of the function of dermis would not be proper. And also, filaggrin, it gets hydrolyzed into various amino acids which are of great importance as natural moisturizing factors in the skin. And nowadays, the market is flooded with creams and moisturizers which comprise of these natural amino acids, namely the pyrrolidone carboxylic acid, short form PCA. If you care to read the contents of the moisturizer that you prescribe to your patients, these are very important because natural moisturizing factor, it maintains the stratum corneum hydration and also maintains the pH of the skin. Now, as if filaggrin was not the only deficient protein in the atopic skin, researchers also found that besides filaggrin, there are abnormalities in the tight junctions. So the skin has got a double barrier in all our skins. The first barrier protection is by the stratum corneum, and there is a loss of filaggrin, loricrin, lipid defects, reduced ceramides. These tight junctions, they constitute the second barrier protection to the skin, and in atopic skin, the tight junctions are also defective. There are mutations. Claudins, they are known as transmembrane proteins, and these are also deficient. So on the whole, if we see what happens in the atopic dermatitis is that because of these genetic mutations in the proteases, the protease inhibitors, filaggrin, all this results in an increased pH and enhanced protease activity which is genetic. Also, it is contributed to by the environmental insult, by the use of soaps, detergents, and infections. It further leads to a breakdown of corneodesmosomes and inhibition of lipid lamellae, resulting in a complete breakdown of the skin barrier. So, what do we have in nutshell is a skin which is leaky in atopic dermatitis. So, there is a very easy passage of microbes, small molecules, allergens into the skin. They activate the Th2 cells and they activate the Th2 mediated cytokine pathways. So this is the barrier dysfunction in atopic dermatitis, which results in reduced ceramides, increased transepidermal water loss. There is a alkaline pH, and there is an altered keratinocyte cytokine profile. So whatever atopic dermatitis we talk about, whether it is extrinsic or intrinsic, we must understand that it is the underlying barrier defect which leads to inflammation in AD skin. Now, all these defects, they lead on to atopic xerosis. We know that dryness of skin is sine qua non of atopic dermatitis, and atopic xerosis is present not only in the lesional skin of AD patients, but the apparently normal looking uninvolved skin also shows disturbed barrier function. So this is very important. As clinicians, as doctors, we have to pay attention to the uninvolved skin of AD also. Dry skin leads to red inflamed patches. So it stands to reason that when we talk so much about the disturbed barrier function in atopic dermatitis, in our treatment plan, in our treatment strategy, we must begin with hydration of the skin by using moisturizers. So coming to moisturizers, basically these are complex mixtures of various substances whose primary function is to make the external layer of skin more softer. These two terms, emollients and moisturizers, they are used interchangeably, and there is very little difference between the two. And moisturizers, earlier, the first generation moisturizers were basically occlusive in nature, and they retarded the water evaporation from the outermost layer of the skin. The second generation moisturizers, they combine humectants along with occlusive agents, and they also had certain irritants into them which were harmful for the AD skin. Coming to the third generation moisturizers, these are the moisturizers which have an additional function of repairing the skin barrier. So this is very important. We have come a long way. So we have over-the-counter moisturizers, and we have another term that you have to be familiar with is prescription device barrier creams. These are being prescribed by the dermatologist, and they have certain additional features which help in the barrier repair. So moisturizers, they can be humectants, occlusives and emollients, and they can be mixtures of all the three. So occlusive agents are, the basic science behind is that occlusive agents, they are generally oily in nature. They are thick, heavy substances like petrolatum, and they form a hydrophobic film on the skin, and they retard the water evaporation from the skin. Nowadays, we have good substances which are occlusive, but they are lighter on the skin. They are known as oil-free moisturizers, and they comprise of dimethicone or silicones. These are non-comedogenic. Humectants, we all know, urea, we have hyaluronic acid. These substances, they draw water from the dermis, or they draw water from the external environment, and they increase the water content of the epidermis. Glycerol is a very effective humectant, but mind you, there is a word of caution here. If you just use a moisturizer that only contains a humectant, then it may rather cause dryness of the skin, because humectant works best when the environmental humidity is at least 70%. So humectant must be combined with an occlusive agent or an emollient. Emollients, as the term itself is self-explanatory, that these are lipids or oils which fill up the cracks between the desquamating corneocytes. So the feel of the skin becomes better, it becomes softer. We now have physiological skin barrier lipids known as ceramides, and ceramides, these are the naturally occurring intercellular cementing substance, and these ceramides are deficient in atopic dermatitis. So one school of thought obviously says that if you replace the deficient ceramides with ceramides, then the barrier repair is likely to be the best. We would see the results, whether it is better or it is the same as any other moisturizer. Then there can be additional ingredients, like there could be antimicrobials, but they always bear a risk of sensitization, anti-inflammatory agents and anti-itch ingredients. So corneotherapy, this is another term which has been coined by the scientists, that if you treat the epidermis, you can treat as well as prevent atopic dermatitis to a larger extent. And what is the importance of using moisturizers in AD is that you are improving the dry skin, and by improving the dry skin, you are reducing the chances of inflammation. You are also reducing the reliance, dependence and usage of corticosteroids. There is a decreased risk of staph infections, and perhaps the future would tell us that this could be an important intervention in reducing the atopic march. There are certain technological advances, like we have preparations which are effective over 24 hours. The patient doesn't need 3 times moisturization. So these are some preparations which are going to be in the market. Now, coming to the systematic review, this is an eye-opener, and this review very clearly tells us that most of the studies they have shown that moisturizers are beneficial, they reduce the transepidermal water loss, but so far the direct comparisons between various moisturizers, they are very less. And this systematic review showed that urea and glycerine, they were better than propylene glycol, lactate, and even ceramides for that matter. So current best practice guideline is that aggressive emollient therapy during the disease flare-ups as well as when the skin is clear is recommended. And how we tell our patients to apply the moisturizer is through a soak and seal method, that after soaking the skin for about 10 minutes, not longer, one should simply use an emollient to retain absorbed water within a few minutes. Now coming to a little more science, where to use a cream in AD. Now creams, they generally contain preservatives, and creams, they have an advantage of being lighter in feel. So daytime use is better, and you have to keep your eyes open. If the patient is not improving, it is better that you stop the cream and switch over to ointments, and they need to be applied every 3 to 4 hours. Lotions are best suited for hairy areas. Hydrating gels are there. They have an advantage that they are non-greasy, they are lighter, and they have a high oil content, and they need to be applied only 3 to 4 hourly. Now another word of caution here is that many a times our patients, they just draw the emollient directly from the pot. And as a result, there are chances of infection. So you tell your patients to use a spatula. Ointments are reserved for use in dry and thickened skin. Do not give ointment-based emollients to patients of acute eczema. Bath and shower oils to be added to the bath, they do not show much evidence in the various reviews. And how to choose the right emollient? I always suggest my patients that first they should try using it onto the dorsum of the hand for a couple of days, and in case there is no reaction, and then it can be used all over the body. One needs to use a lighter emollient during summers, and during winter season you can give good dose of occlusive agents like petrolatum, but please do not use heavy emollients like petrolatum during the summer season, because there is a risk of folliculitis developing. And also how to apply the emollient. We hardly ever tell our patients about that. Patient is asked to apply small dots onto the skin and asked not to rub up and down. This is specifically for atopic dermatitis, because if you ask the patient to rub it on the skin, that gives rise to itching and folliculitis and flare-up of eczema. So emollient should be just gently applied onto the skin in the direction of hair growth. And this has to be used at least twice a day, every few hours if the eczema is flaring. And there are various guidelines now. The various associations all across the world, the NICE, the British Association of Dermatologists, they have now taken this up as an important aspect of management of atopic dermatitis. There is no consensus as yet, but they say that it is better that you apply the emollient first, followed by at least 30 minutes of interval between application of emollient and corticosteroid or non-corticosteroidal agents. But I was just going through the literature recently, just in 2016 Pediatric Dermatology Journal, there is an article, a randomized controlled trial, which says that it is immaterial whichever way, whichever order you apply these two. You can apply the steroid first, followed by emollient, or you can apply the emollient first, followed by the steroid. So please go through that article. And now coming to the moisturizers, there is a galaxy of different kinds of moisturizers available in the market, from creams to oatmeal to olive oil and so on and so forth. I would just confine myself to basic don'ts. So in infants, if you have an infantile atopic dermatitis, I would suggest not to use oat products, because they have a risk of causing sensitization because they are proteins. And olive oil is no longer considered safe use in case of infants, because a study in pediatric dermatology where they compared olive oil with other oils, it showed that olive oil resulted in erythema and a flare-up of dermatitis. So when we say that we use herbal oils, vegetable oils as a blanket statement, it is not true. Sunflower oil is it shows better results, and it is recommended these days to use sunflower oil. For infants, do not use moisturizers which contain fragrances. So this is for those practitioners who rely heavily upon commercially available products which have preservatives, fragrances, because they have allergens in them. Then there are certain other baby products which may contain things like propylene glycol, which can give rise to skin irritation, and glycerine, if it is used over a large body surface area in infants, can give rise to these risks. So please play safer in infants. Now, coming to ceramides, they have a high cost. These are naturally occurring lipids. Now, these studies, they have shown that the application of ceramide complex, it does improve the stratum corneum lipids, and a double-blind control study also showed that there was a significant differential benefit of using ceramide complex over the vehicle alone. But this was a trial with just a vehicle. Although apparently these moisturizers, they seem to be better, but there are other trials which have used things like glyceretinic acid versus ceramides, and the study showed that there was mild improvement. There was improvement in mild to moderate atopic dermatitis. Now these are the newer agents that are used, and there is good evidence for their efficacy in the treatment of atopic dermatitis. But whether such treatments lead to an indirect restoration of ceramide levels, it is not yet proven. Now coming to emollients with urea. Urea is good and they are the standard emollients, but their use in children has not been proven so far, and do not use it on a very dry skin because it can be irritating. Now this is a very interesting study whether application of emollients can prevent atopic dermatitis, which says that prophylactic emollient use beginning at birth prevents atopic dermatitis. So this is a path-breaking study and a thought, and this can be true to some extent because this study showed that emollient application after birth in high-risk infants, it resulted in a reduced incidence of atopic dermatitis. Now this is another trial which I wanted to show you, that comparison of an emollient containing a ceramide dominant barrier repair cream versus a simple over-the-counter petrolatum based emollient. It showed that petrolatum is as effective in treating mild to moderate AD as both these newer moisturizers, and is at least 47 times more cost effective. So this is a message for those who treat poor patients. So coming to the conclusions, I would just like to summarize that daily regimented moisturization of the skin is very important tool in preventing the flares of atopic dermatitis, and the choice and your selection should be based on the age of the patient, cost, severity of eczema, and the weather conditions. Ceramides, they show good results, but evidence is still developing, and we need additional research to warrant the superior efficacy of ceramide-based emollients in atopic dermatitis. Thank you so much for your patience.
Thank you, Dr. Vibhu, for your excellently illustrated and exhaustively reviewed talk. Now I request Dr. P.N. Arora to conclude the session.
Ladies and gentlemen, we had excellent presentations from both the speakers. They were very self-explanatory. But if there are any questions still left, please go ahead. Yes, there is one.
My query is to Dr. Vibhu, and I wanted a comment on ichthyol pale use in atopic dermatitis.
There are several group of emollients that we use, and ichthyol pale is basically a product derived from the coal tar. It is supposed to be anti-inflammatory. The additional benefit is this. But these coal tar derivatives, they might irritate the skin. So there is word of caution. If you ask my choice, I would confine myself to the basic emollient, the petrolatum or simple coconut oil. That would be better, because there is a risk of irritation, secondary irritation that may be there. And
Dr. Srinivas,
also
please.
the literature mentions that if you use coal tar derivatives, there is an risk of, though it is a long-term risk of malignancies, but there is a risk of malignancies, squamous cell carcinoma, in those who use tar preparations.
This is Dr. Ganju. This is regarding this nail. First is when you, for the fungus, you said we can use onychomycosis. It is likely to reflect the light on your face when you are doing with this, so reflection is likely. And what is the depth to which it is going to penetrate deep enough? And third question is it possible that we only focus on the nail, because there is a possibility that we may induce depigmentation in the nail fold, and that may again cause some other problems. So how do you take precautions to avoid those?
Sir, I don't have personal experience in treating onychomycosis, but what is mentioned is that with this particular pulse width of 300 microseconds, you are able to heat only the mycelia and spare the surrounding skin, so that the collateral damage does not happen. And at this pulse width, the mycelia typically absorb more light and get heated more rather than the surrounding tissue. So we selectively heat the fungi and take them to a temperature of about 55 degrees centigrade and kill them. Also, because you are using this pulse width, the surrounding skin is not heated so much. And what is the depth? The depth, the best wavelength that would treat it would be the 1064 nanometer, which would. Yes. It is possible, if the nail is very thick, that we might not be able to reach the whole of the depth of the nail. But whatever distance can be reached in that area, in the nail plate, not in the nail bed, in the nail plate, we can kill the mycelia. Probably yes, but that's not what they have done it in the studies that have come up till now, sir. That did not come across. But yes, definitely, if we have a very thick, distorted nail, filing it and pairing it probably will help.
Dr. Ramesh, please.
Thanks. My question is again to Dr. Anil Ganju. He showed good practical experience of treating melasma with laser. And some of the cases which he showed did not respond to this thing. They had a sort of speckled hyperpigmentation. I was just wondering whether he considered exogenous ochronosis in such patients, because that doesn't respond to laser.
The response, no sir, the response has been universal. Most of the patients did respond. Many of the patients showed rebound hyperpigmentation and relapse of melasma. Yes, you can think, but see, ochronosis usually, clinically also to a large extent, you can make out what ochronosis is compared to melasma. The pigmentation is different. You have slightly papular presentation, and the hue is slightly different also. And of course, some of the non-responders may be something other than melasma, including ochronosis. But as far as response is concerned, most of my patients did respond, sir. Some of them showed a relapse, which could be taken care of with, maintenance settings at longer intervals, maybe a month or so.
The last question, Dr. Ramesh.
My reason for asking you this was we presented to the IIDBL meeting in our Sultan Hospital, where the patients who did not respond were biopsied because they were troublesome patients, and it showed the evidence of exogenous ochronosis. So maybe a biopsy would help in taking these patients. Thanks.
Okay, Kar was the last one to ask the question. No more questions after this, ladies and gentlemen. You can start.
Just a comment on Dr. Ganju's paper. when I was in RML, we did a series of works on melasma with NDIAC laser. Probably he has not shown it. Initially, we tried to do it with high energy and low energy. We compared it, giving larger spot size, low energy and weekly, and we get tremendous, very good effect as compared to higher. Then we compared with the chemical peels with, we find NDIAC low energy is very good. And then we tried using azelaic acid, combination of azelaic acid and low energy NDIAC